Hi everyone, today we're talking about this disease called apparent mineralocorticoid excess syndrome. Now, what happens is that we have mineralocorticoids and we have glucocorticoids. Both of these hormones are secreted by our adrenal glands. Now, under the classification of glucocorticoids comes cortisol and corticosterone. These are two examples of glucocorticoids. And principal example for mineralocorticoid would be aldosterone, right? Now, what exactly happens is that we have mineralocorticoid receptors. Now, ideally, what should attach to mineralocorticoid receptors? Yes, aldosterone, and it should render it active, right? But what happens, not just aldosterone, but even cortisol primarily, even it is capable of activating mineralocorticoid. And there's another very important and interesting fact that is that the mineralocorticoid activity of aldosterone, obviously it is 3000 times greater than cortisol, and rightfully so, because this is the principal mineralocorticoid, so its mineralocorticoid activity should be greater. But here's the catch: the plasma concentration of cortisol is nearly 2000 times greater than that of aldosterone. So cortisol is in abundance in our blood plasma. So what happens is that there are great chances that this can act on mineralocorticoid receptors and activate it. But thankfully, our body is designed in a way that it has this very important enzyme. This is the abbreviated form, and the full form is 11 beta hydroxysteroid dehydrogenase type 2. What does this enzyme do? Is simple. It converts cortisol to cortisone. Once cortisol is converted to cortisone, now this won't evidently bind mineralocorticoid receptors, and it won't activate those receptors anymore. Thankfully, our body is now safe because these receptors now will only respond to aldosterone, which is the principal mineralocorticoid. And cortisol has been converted to cortisone, thankfully, because of 11 beta hydroxysteroid dehydrogenase type 2. Now, what happens in this disease is that this enzyme, it is deficient. So in this disease, the entire issue is that there is deficiency of this enzyme, because of which cortisol is unable to be converted to cortisone, and there's so much cortisol in blood, as I've already told you, its amount in blood is 2000 times greater than that of aldosterone, and it is going to bind to mineralocorticoid receptors, and all of that pathophysiology, the patient is going to experience all of those issues that he will experience similar to excess aldosterone. So, whatever in hyperaldosteronism, all of those symptoms will start appearing. But the lab report is going to show decreased aldosterone. So, doctor will be quite confused that why, even though all the symptoms that this patient is showing are of hyperaldosteronism, why is he not having increased aldosterone level? So, the answer is because actually the increased levels are not of aldosterone, but they are of cortisol. Cortisol is quite high, and that is activating this receptor, and this is showing all of those symptoms of excess aldosterone. So, the same pathophysiology. That's the reason lab reports are showing low aldosterone. So, what's the deficient enzyme? This. So, this is the basic. And it's very important for the patients to avoid consuming licorice and glycerinic acid, because these can cause AME. And how do they do that? Because they inhibit the enzyme, or they block the enzyme 11 beta hydroxysteroid dehydrogenase type 2. So, yeah, and this is the definition. It's a rare autosomal recessive disorder which is caused by deficiency of this enzyme, which is 11 beta hydroxysteroid dehydrogenase type 2, leading to excess cortisol acting on mineralocorticoid receptors. And what does this enzyme do? It converts cortisol to cortisone by rendering it inactive, and now it won't activate those receptors. But once this is deficient, what will happen? Obviously, cortisol is going to bind to the aldosterone receptors, and it is going to give all of that pathophysiology of aldosterone excess. So, yes, that's pretty much it.